Well, Dr. Andrew Foy, welcome back to Healthcare Unfiltered. Let's try with a quick intro, and then we're going to try to remember why we're doing this podcast together.
Yeah, so I'm a general cardiologist. I work at Penn State, Milton S. Hershey Medical Center and College of Medicine in Hershey, Pennsylvania. I'm an associate professor of medicine and public health sciences. Mostly what I do is clinical clinical work at this point in my career. I'm involved with some education, um, and some research, but less and less as sort of my career's going on. And that's that.
You dabble a little bit. I think you have some strong opinions about certain things pertaining to healthcare policy and some of the regulatory aspects and things like that. Was this something that you just kind of acquired, became interested in? Did you get like formal training in it? Like I do see some of your opinions more like policy side, regulatory side.
Yeah, so um, I don't think anything that would be considered formal training in it, other than just sort of my college and medical school training. But I did get very interested in economics, particularly Austrian economics, when I was in medical school. And I essentially just did a lot of reading and self-teaching. And I guess that sort of led me to have some views on healthcare, which are slightly sort of, I guess, different than what would be like mainstream kind of right or left views. I guess they would put me more in like a libertarian realm. And I have written about those things in even in peer review in medical journals and even in policy journals. Um, so I guess that gives me a little bit of experience, perhaps, but not much in the way of formal training.
Andrew, we are taping this show on October 15, 2025, and it's going to air after November 2024. I'm sorry. It's going to air after November 5, 2024. And you are in the great state of Pennsylvania. So your vote, actually, believe it or not, is important. You don't have to tell us who you're going to vote for because we don't want to have 50% of people canceling you. But just know that your vote is important. So go and vote.
I intend to.
All right. Excellent. So So I recall we started having kind of more of a discussion over text, me and you, pertaining to pharma as an industry, academia as an industry. You had certain strong views about pharma, maybe influence on academics, maybe influence on medicine, and things of that nature. So I invited you to share these views in a long format, and I told you I may need to challenge some of these views and have a healthy debate. But I believe this is how it all started a couple of months ago. It just took a while until we arranged for it.
Yeah, and I mean, it probably is related to earlier in the year. I was involved. I was a senior author on a paper that looked at payments, industry payments to physicians. It was published as a letter in JAMA, and I think some of the conversation may have stemmed from that. But I mean, I have for most of my career had concerns about conflict of interest that arise when physicians receive payments from industry. And I've had concerns about the relationship um, of industry with physicians and how that influences guidelines and recommendations and even quality of care measures for practicing docs. And I think I have had concerns also for a long time that some of our recommendations are based more on sort of protecting the interests of industry than necessarily putting the best interest of patients first. And I've not really been shy about that uh, in my career. And all that being said, um, I believe that I'm as much of a capitalist as anybody. I love the free markets, but I don't like captured agencies or captured institutions. And I don't think that our current healthcare system operates in a free market. And I think that some of the distortions that we have in terms of prices and cost of the entire system, and what is borne by individuals and taxpayers, is sort of a result of, I think, screwed up system, screwed up payments, and um, protecting private interests to a large extent.
I think having these concerns is very important, and I think it's critical to self-reflect and have concerns about the entire thing. So we'll go over this. We'll try to dissect this a little bit to better understand where the concerns are and things of that nature. But maybe it's a good stepping stone, Andrew, to maybe share a bit about the paper you referenced. Folks may have not read the paper. Are you maybe give us like, 2 to 3 minute kind of high level summary of that paper and what led you, like what methodology you used and what made you think about looking into this, the database and things of that nature?
Yeah, so it was actually, this was led by Ahmed Syed, who's actually a medical student in Egypt. He's a really brilliant mind, and has really high level skills as far as data analytics goes. And his desire is ultimately to come to the States and to do training and fellowship here in cardiology. Um,
Hey,
and
a JAMA paper is a pretty good start.
Well, you would think, but I'll tell you, this young man has probably over 100 publications at this point in his life. And in my experience working with him, I mean, he's very much investigator initiated. He comes up with ideas and interesting ways to sort of test those ideas with data that is available to him, and techniques that are available to him. Um, he's very ambitious. He had an idea for a project to look at payments to cardiologists, industry payments to cardiologists. He approached me, I suspect just because of my history, sort of, I guess, challenging some of these things and making it known that I think maybe the relationship is a little too cozy. I don't know. That would be my guess. And so he emailed me. Now, you probably know this as a physician, and I believe you did work in academics at some point in your life, correct?
Yes,
So I mean, I'm sure you can recall getting emails from like foreign students asking
right,
if they can work in your lab, and it often seems like these emails are probably like mass emails, and they find your name because you're a corresponding author on a paper, and they then it leads to this
right,
sort of
right.
blockchain email kind of thing. So you get used to seeing them, and you normally just delete them. Um, but this guy didn't send a sort of a block email. It was a very personalized email. And instead of just saying, I'm interested in your work, I want to work with you, he said, I have this idea to do this project. I have the ability to get the data from open payments, which is the data source. And then he talked about ways in which he could analyze the data to sort of to come to some descriptive, I guess, conclusions. And so anyway, we just talked about that. We met several times over Zoom. Some other investigators were involved, who we had also sort of sought their involvement. And we just decided we didn't want to just look at cardiologists. We wanted to look at all specialties. We wanted to look at differences between like the median and the top earner, so to speak. And then we also wanted to look at particular products that were sort of like the highest, um, what the products where the most payments were being directed to, and categorizing those. So it was an entirely descriptive study in that regard. And I mean, I would say the main findings were that approximately half of physicians receive payments from industry. The average payments on a yearly basis is not particularly large. However, there is a chunk of physicians at the top who are receiving extraordinary sums of money, and and when I say extraordinary sums of money, I mean seven figures a year. to
Seven figures,
basically,
over a
you
million.
know, to market industry products. And so we described it. We described some of the individual products, which most of them were in the cardiology realm. We looked at medicines, we looked at devices, and they were ones that I think most people would expect. Some of the devices in particular didn't have the most compelling, I guess you could say, like highest level data behind them to support their use. But all of the products that were being used, I mean, they weren't investigational by any sense. I mean, they were products that had been tested in clinical trials and found to be of some uh, benefit. And so it was a descriptive study in that regard. I think some of the top numbers in terms of what the top 1% were making were probably the shocking finding from it. Um, and and that was the paper. So I mean it didn't test a hypothesis, let's say that industry payments to physicians um, led to any sort of good or bad outcome. All it was just a descriptive study of payments, and people can sort of think about how they may want to spin that or not. I did get a lot of requests for interviews after that, and my response was that I
Requests,
didn't really want
requests from who, Andrew?
media who wanted to do stories. And I think a lot of people were looking to sensationalize the results. And I tried to be pretty cautious in how I spoke about them, just saying that, you know, this was a descriptive study. We maybe didn't even need to do this study. I mean, it was already, most people would have said it was obvious that industry has a lot of influence on physicians and their presence at things like society meetings and advertising in medical journals is not really something you have to research to find evidence of. I mean, it's not being hid. And but then the question is, does this lead to is this better or not for patients or better or not for physicians? And I mean, our study couldn't answer that.
No, and your study doesn't necessarily prove influence. It proves payments. In other words,
Yeah.
well, it for so let me back up a little bit. Like when you propose that a physician is influenced by pharma, at least what comes to my mind is two things. One of them, actually, I don't think it's terrible. One of them I think is awful. So an influence to me is that if there are two compounds that are similar to each other, let's take a statin because I'm not a cardiologist. Let's say you've got two statins, both of them are as good, and I'm getting paid so much of the manufacturer of one statin, I'm probably going to prescribe that because I don't think I'm hurting my patient clearly. It's both the same. And hey, I've been speaking for this statin for a while, so I became interested in it. And we can decide whether it is bad or good. But I think the worst thing of influence is if we think that by getting these payments, this is leading to inappropriate prescribing in situations where you're not supposed to prescribe, or to prescribing an inferior drug to something that's better because you're getting paid. That's where I think is clearly the problem. I clearly your study can't address that. Are you thinking of doing another trial to attempt to dissect that?
Um, so right now, we don't have any additional studies in the works. Mm, there's other people that are studying this. Um, there was something that just came out either this week or last week about industry payments to journal reviewers. And interestingly, the median payment to journal reviewers was much higher than the median payment to all physicians that we categorized in our study. And I suspect the reason for that is because journal reviewers um, probably make up physicians at sort of the higher echelons of academia, who are also tend to be a lot of these people that are, eh,
Yeah.
getting more payments.
Why do you think physicians get more scrutiny about this and criticism about this than societies? You already mentioned, and I can't agree with you more. You go to any of these large society meetings, and millions of dollars are being spent in the exhibit hall, whether it's cardiology, oncology, rheumatology. Yet it seems to be the norm. It's accepted. You don't really hear anybody say, at least I haven't heard, like publicly, people say this is an awful oncology society or cardiology society because they're doing this. Isn't that another form of attempting to influence at a much larger scale and it doesn't get scrutinized as much?
Yeah, well, I think that the individual physicians make up the societies. And so I think that criticism of the individual physicians is not, I don't look at it differently than as criticisms of the societies. But I do think to like the average person, the societies are much more opaque than individual physicians. I mean, everybody knows a physician. The average person has no idea what constitutes a medical society, right? Or the American College of Cardiology. It's just an idea, but they all know who their cardiologist is. And so I don't look at the societies as just being more than just a composition of individual physicians. So I guess
Okay.
that I would say that. So I think that payments to the individual physicians, you know, I don't necessarily separate it from the society themselves.
I
Even though
mean,
I appreciate that they are different, it's going to ultimately different.
no, I hear what you're saying. I just don't see the same criticism. I don't see, like, I hear, but let me back up
But
just
well,
a little bit.
but don't you think that's because it's not? So from a public standpoint, the public has no idea what goes on at the level of the society, and I think that a lot of people that are involved in these societies accept it. I mean, so I will tell you that I'm actually not part of ACC or AHA. I made a decision when I became an attending that because I didn't like what I considered to be this influence at play, that I wasn't going to become a member of one of those societies or a fellow. And maybe it's even hurt me in academics, but I just felt like I did not want to um, I didn't want to volunteer myself, for that. I didn't want to be able to write FACC on my white coat or FAHA, right? And even though people told me that this is what you should do if you really want to, um, climb the ranks of academia, like you need to involve yourself in these societies and climb in these societies. And I just said, I'm not going to do it that way, and I have published over 100 papers, but it's very, it's been a very independent endeavor. And I didn't want to be a part of that. Now, I go to those meetings. Um, Occasionally I'll submit science to those meetings, especially if it involves medical trainees, because it's beneficial for them, I think, to attend and present their work. I don't really try to present, individual stuff at those meetings anymore. But um,
Hmm,
yeah, I didn't
interesting.
I didn't personally want to be a part of that. Now, so I think if you say, so who's going to criticize it? I mean, the physicians in the societies, even if they're uncomfortable with it, they're making a conscientious choice to be a part of the society. And then there's that cognitive dissonance. I mean, the people that are inside aren't going to criticize it. So then it's how much do the people outside of it actually have access to it? And I mean, unless you're a worker at those venues, when these things come to town, you really don't know.
Okay, so let's go back to the influence though. Do you really think deep down inside, I know we have no probably study to, at least I'm not aware of one, that these payments are leading to inappropriate prescribing habits?
I do. I think at the level of the individual and at the level of the medical societies themselves. And where I think it's biggest is in expanded indications for drugs. where they're expanded well beyond the eligibility criteria for the clinical trials that they're based on. Um, well, so I think that that's one. And then also just the acceptance and uptake of products that wouldn't pass that bar if they were just being evaluated by truly independent um, physicians that were able to think critically and scientifically. And I can give you examples of that in
Let's do
cardiology.
one. Let's just do one example.
Entresto.
Okay, tell us about Entresto. What
So
is it?
Entresto is a combination drug. It uh, new to the market probably seven-ish years ago in patients with congestive heart failure. Um, Part of the treatment for those patients requires reducing afterload. That improves, I'll just say to make it sound simple, that improves cardiac efficiency and can manage symptoms of heart failure, can reduce hospitalizations, and improve uh, longevity for patients with heart failure. So to reduce afterload, there's been products that have been around since the 80s that do that. The most significant ones would be angiotensin converting enzyme inhibitors and angiotensin receptor blockers. And we have many, many clinical trials showing that they're beneficial in patients with congestive heart failure, whether it's acute onset, post MI, or whether it's chronic stable patients. Um, those drugs have been generic forever now, whether we're talking about ACEs or ARBs. And so they don't cost very much. This new drug came about that included an ARNI, an angiotensin receptor neprilysin inhibitor that basically works on another part of this pathway, and it reduces afterload, and it has to be used in combination with an angiotensin receptor blocker. And, the idea was, is this new drug better for patients with congestive heart failure than sort of the old standard, which is ACEs or ARBs in and of themselves? Um, the main clinical trial, which has sort of led to I wouldn't say just the uptake and adoption of this drug, but making this drug actually surpass ACE, like, your plain old ACEs and ARBs in clinical practice guidelines, is a trial that I think was a very gamed trial because of just how the trial was conducted. It basically ended up showing a positive result, and that positive result has never been able to be replicated in a subsequent trial since. And instead of, there just being a recommendation in our cardiology guidelines saying that Entresto can be used, you know, interchangeably with ACEs or ARBs as first line therapy, our guidelines say it should be used as the first line agent with ACEs and ARBs second. However, the drug costs 20 to 50 times more. People don't pay for it. Health systems pay for it. People that pay for health insurance, and their premiums pay for it. But that sort of individual conversation with a patient of, do you want to take this drug or would you, just take an ACE or an ARB? I mean, I believe that 99 out of 100 patients, even if they had no issue with, they were the richest person in the world, I don't think Elon Musk would take Entresto over an Allopril or lisinopril if he had to pay for it out of his own pocket. Because he'd say, based on the evidence here, I wouldn't pay 20 or
But don't
50
you,
times
but
more for this product.
right, but don't you think that this is not sometimes, most often, it's not really the physician's choice. So that's why it's not really influence from pharma. This is the payers. This is a relationship between the payer and the manufacturer. They could be rebates, right? They could be rebates. They could be discussion about putting this number one on formulary, where if it's not, then the patient's going to pay more out of pocket cost. I guess what I'm trying to say, it is possible in many of these situations that if you prescribe that drug, it get denied by the plan, although you want to prescribe lisinopril or captopril, but it just gets denied because the plan says, well, if this is the one that you should prescribe. This does happen.
Yeah, but I think in this particular case, so let's say this particular trial was when it came out, the cardiology community said, this trial doesn't prove that Entresto is superior to a maximized dose of enalapril or valsartan by itself. Um, and we're not going to accept this single trial to show this. I mean, there's no payers that would pay more for that drug. I mean, the
But they may
physician
not be paying more.
community,
That's my point. They may not be paying more. It's a
oh,
rebate.
they're paying more. There's no way they're not paying more.
I'm just saying, I just don't know what the relationship between the payer and the manufacturer that could be, let's say you're a manufacturer that you have like three or four drugs. You go to United Healthcare and say, as part of this package, if we put this as top formulary, you'll get the rebates. I mean, payers are not stupid. If you look at their stock prices, it's the one that keeps going up and up. So I presume I guess I just want to try to sell the point, and I hope you agree that sometimes these decisions are not entirely purely physician driven. Sometimes you're really uh,
Well, no,
forced to.
so I agree with you that they're certainly not driven by individual physicians, but I think that they are physician driven in the sense of it's the society, it's the medical societies or the specialty societies which are ultimately determining um, where do these products fit after their clinical trials sort of come out? And the if the clinical societies say that, yeah, sure, your trial passed with the FDA, but it doesn't prove that your product is superior to ACEs or ARBs, and it certainly doesn't suggest that the value there to the public, you know, supports a markup. I'm not going to say markup, but supports a price that's 20 to 50 times more. I mean, then the market for it, there is no market for it. It's entirely created once the trial is basically published and it's endorsed by the societies.
Right, right. I'm just saying that
But
I'm just
those
saying,
societies are heavily, one, they're made
yeah,
up of
yeah.
individual people, and the influence on
I,
them from industry is incredible.
I guess what I'm saying is that I think it is that now you have a new entrant to market with this new drug, and it's just a matter of where it is positioned in the marketplace. But I think going step back, Andrew, and every entity in healthcare, they have their own interest, except physicians and patients, unfortunately. I mean, I'll throw an example: hospitals and payers and pharma. These are like three major sectors. But hospitals, they have huge lobby in Washington. They have their own agenda. And you and I know that the hospitals I worked at and the hospitals you work at, there are certain advertising, certain programs, certain things that really take place that are really designed purely to bring patients in so you could do tests and procedures and things like that that are going to bring revenue. Um, I'm not defending one sector or another. I guess I'm trying to suggest it seems that this is the world that we live in healthcare in America. It's a very capitalistic world, which you and I believe in, but because of that, there's a lot of money talks, there's a lot of influence and lobbying and all that stuff.
Well, sure. I mean, I can agree to that. But I guess what I don't see is how capitalism per se uh, would facilitate the price of one product that's not much better than another product being 50 times higher. In
I
fact,
guess,
capitalism would destroy that
let me give you an
if it was
example.
allowed to work.
Right. Let me give you an example. Imagine you're coming to a hospital, and this hospital has just bought a new MRI machine, this like better than the MRI machine that we normally do, that we have, or a new mammography that is better than the next one. But the reality is they're the same, they're just fancier. I think, I think without a doubt that there will be so much advertising to consumers to drive them to this new machine, to drive them to this technology. There probably will be incentives to the physicians and the physician organizations to refer these patients. I mean, it happens every day in America.
Yeah, I guess I agree with you, and I don't think that's necessarily a good thing either.
No, no, it's not. I'm not defending it. I guess well, and I'm not defending it. I think we started by saying pharma influences physicians, and what I'm suggesting is hospitals influence physicians, payment payers influence physicians. I think that, if you were at a particular hospital and your salary is driven by RVUs or by whatever it is, there's a subconscious that may make you, I don't know, bring patients a bit more, maybe order a PET scan, maybe a calcium scan, maybe a couple of echoes here and there. You could always justify an echo for any cardiology patients. So I'm where I struggle with, and the reason we're having this podcast, I feel the pharmaceutical industry gets a lot of like, backlash or lots of scrutiny, while we consciously ignore other sectors of healthcare that have influence simply because they pay your salary, simply because, it's just more convenient to badmouth the GSKs and the Mercks and the Pfizers, but it's really taboo to badmouth UPenn or Penn State or Fox Chase because your chair will call you to the room and all of this. And I'm not suggesting you should. I'm just saying, in all transparency, we should, if we really want to look at healthcare ecosystem and influence and what's going on, I just find people get always the convenient thing. And I've had this argument with a couple of our colleagues before, and the response I got was actually pretty interesting. One colleague responded to me. He said, "Well, I'm just focused on this sector of the healthcare system. That is my thing. My thing is the pharmaceutical companies and their influence. I'm not, other people have them focus on the hospitals and other things." And I find this like a cap out. I find like if you really talk about physicians being influenced, let's talk about everything and everybody that influences physicians.
I think that's totally fair. I mean, for what it's worth, yeah, I mean, I think that that's fair. I don't think that I don't
Don't you
view,
find it it's always convenient to criticize pharma? Like you come across as the knight that is really saving patients from the evil pharma, who I believe has brought more drugs to market and helped patients than any academic center in the entire country.
yeah, I mean, that's your perspective. I mean,
Hey,
look,
challenge me, come on.
I don't think that we've had really any, I don't think that we've had a ton of tremendous breakthroughs in my lifetime in medicine. I mean, and all I can really speak to would be what I've been the most engaged in over the past, 20 years of my life. But I don't really view anything that's happened as being, I don't, not a lot of huge game changers. I mean, I think we've plucked off a lot of the low-hanging fruit. And I haven't seen a lot of game changers coming out. I mean, I think we've seen life expectancy, I mean, it's a terribly crude metric, but I mean, if you look at, let's say in cardiology, for example, I mean, as far as heart disease mortality goes, particularly in relation to congestive heart failure mortality, it's begun to increase over the last several years after, it was sort of, or, when after it was sort of improving for many years. But over that time where it's been going down, we've brought a half a dozen new things to market, right? And I think, what I see a lot is this sort of creeping incrementalism, which carries with it huge costs. And I don't necessarily see value in terms of like the health of individuals or the public to necessarily justify those costs, would be my opinion.
So
And I mean these are the biggest, companies in the world, so to
yeah.
speak. And I guess, my thing is, like I said, I don't see the value there. But I mean, I think it's debatable.
I mean, I think we've had some look. So I'm a firm believer, by the way. I mean, I obviously I like to challenge my guests and everything, but I'm a firm believer in collaboration. I mean, I actually don't think I think that pharma needs academia and academia needs pharma to work together towards one thing. I don't think genuinely, I don't think one could do things alone. Um, but I do think that I do firmly believe that it's always easy on people to criticize pharma because it's it's I don't think
Well,
they're
I'll be honest. I don't really find I don't feel as if I'm criticizing pharma.
the
I
influence.
I I personally feel like my criticism is leveled more at physicians and the physician community. Um, Nobody gets paid involuntarily,
Right.
right? And so I think that pharma is doing what you would want or hope for pharma to do if you were a shareholder in one of those companies.
Is
I
open
don't
payment
think,
accurate though? Is open payment that accurate? Because
yeah,
sometimes they mix things with
I believe
research
that.
grants and
No, I mean they're pretty good at separating those things. I mean, I can't say that it's 100%, but I think that that's fairly accurate.
Mhm.
Um, but still though, I mean, I don't view what pharma is doing. I don't think it should be made illegal, for instance.
Right.
I think if they want to pay physicians to give, to give talks that they create to other physicians, um, I don't necessarily think they shouldn't be allowed to do that. Um, but I think it has a significant influence. I mean, they're not paying them. I mean, they're paying them to be influential, right? I
Right,
mean, they're
right, right,
paying
right.
them to market and advertise. So
No
I think it
question.
would be silly to think that the payments aren't influencing. I mean, that's what, pharma's not stupid.
No, no, there's no question they know why the money is being spent. I guess, like I told you, in my mind, the bad influence is if this is leading you to prescribe an inferior product for a patient, unnecessary subscription and things like that, prescription. And I can buy that this probably happens. I mean, I think without a study, I'm willing to accept that this likely happens. I think it doesn't happen as often as probably people say, but I'm willing to concede that it probably happens here and there.
I mean, I think we have entire classes of drugs that wouldn't be being prescribed if it wasn't for the influence of the industry on physicians. Now, but I think there's always going to be a reasonable argument to be made that is it for the greater good or not?
Mhm,
But I think that's where the back and forth is. I
mhm.
mean, again, I think I can't really think of one prescription for Entresto that is truly necessary or significantly beneficial over a maximized dose of an ACE inhibitor or valsartan.
Is it the
But the
most
cost to
prescribed?
society is huge.
Yeah.
It's absolutely massive.
Is it the most prescribed after load reducer, Entresto?
I don't know the answer to that right now. I mean, it's the guidelines say that it should be prescribed as the first line agent.
Okay.
And I mean, I will tell you that what I've seen in my community, at least, is that it is the number one prescribed.
And you know, one of the problems, Andrew, is I think sometimes if this is what the guidelines say, I presume physicians start worrying about litigation and things of
Oh
that
yeah, well,
nature.
100%. That's my point. That's
Right.
what the guidelines say that for.
Right.
I mean, that's where they are able to exert their greatest influence.
Yeah. Because now like, subconsciously you worry if I don't really do this, they can come and sue me and things of that nature. So, 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 okay. I mean, we agree on few things. We agree that there's influence. We, I think you probably didn't agree with me that um, other sectors of healthcare influence physicians as much um, as pharma. I think it's just indirectly. I think it's not really visible. Um, I know of, look, I know of physicians in oncology. I literally know that. These physicians will probably bring a patient back to the to be seen, and a woman could have had stage one breast cancer 10 years ago. 10 years ago. The likelihood of this woman really having any recurrence is almost zero. It's nothing, it's never zero, but it's close to that after 10 years. But because you bring that patient back twice a year, you can build level three or four visit, and it's indirect, but I think you need to meet your target. Um, it's, I guess, how do you get out of this when everything is intermingled with each other? I mean, you really know that, I mean, in your specialty, how many times do echoes get ordered for no reason? How many stress tests get done inappropriately? I don't know. In my specialty as well, similar to your specialty, and I don't think pharma pushes you to order an echo. And I know
Well,
Echo
I
is
don't.
cheaper. I know Echo is cheaper than others, but how do we get out of this? How do we get out
Well,
of
I see. I feel like that's something altogether, right? I mean, you're really making an argument theoretically against fee for service and saying that fee for service influences, what physicians will do as opposed to if they were just getting paid a salary. And I think that that's a fascinating topic and worth, exploring, but I don't think it just doesn't have anything to do with this. I mean, it's because I think that like this is one, topic and it exerts a significant sort of pressure and influence on healthcare decisions. Um, and it's sort of like, your question is like, well, what about other areas? And I think that that's a totally valid question, but I don't think it's, to me at least, I'm not going to sort of withhold my criticism from this one thing just because there's other things that could potentially be criticized, I suppose. And
yeah,
and I
yeah, no,
don't and I think when it comes to fee for service, I mean, that's really jumping into like
I just
uh
want your criticism to be even across the board. That's all. I'm not
well,
telling you don't criticize pharma. I just want it to be equally
but
critical.
even when it comes to, let's say, fee for service, I mean, I would be highly critical of physicians that are doing unnecessary things or more costly things just to generate more RVUs. I mean, I spent my first 5 years of like my career, my research was involved at like comparative efficacy of different testing modalities, and oftentimes I've been an advocate for sort of cheaper things that were equally effective. And I think that gets right to the heart of criticizing this issue of like fee for service of uh, you know, of sort of these misaligned incentives. But I mean, the ultimate thing that would align incentives is if patients had to pay for more things directly. And then, you don't have to worry about the indirect influence on a physician because you have to convince a patient to do a PET stress test over a treadmill EKG or a stress echo. And if you said, well, the one test costs 200, the other test costs 800, and the third test costs 2000, hey, that's going to influence people more than any sort of indirect influence it has on the
Uh,
physician, right?
I agree 100%. I agree 100%. I think once it comes to out-of-pocket payments, for sure, there will be influence. And I think that's a very, very broader topic. I
Right.
actually had some of this conversation with Anish Koka, who came on my podcast several months ago. But let me ask you in the last 10 minutes, just a couple of things I think worth discussing. One is I wonder if the drug prices were lower, right? Then pharma maybe does not need to have that much of influence because even if the prescriptions are done, the revenue is not going to be that high. With that in mind, A, do you agree with this? Number two, what are your thoughts on the Inflation Reduction Act, which is really a law that was passed specifically to attempt negotiating drug prices, although it's only like 10 drugs for now. But any thoughts on that?
Yeah. Um, well, so I'm all for the government negotiating drug prices. Um, I don't think that US citizens should be paying any more for drugs than citizens in other first world countries. And I think that coming up with drug prices based on R&D costs is completely antithetical to capitalism. I mean, a drug price has nothing to do with the cost of developing new products. It has everything to do with the value of the product to the individual consumers. Now, theoretically, it's really hard to figure out what the value is when you take away all of the benefits of a free market. So then you're just sort of trying to make these determinations theoretically, and it never really works out. Um, but I think anybody, if you just say the price of, this product is this much more effective, it will reduce a non-fatal event by 30%, which is an absolute risk of, 1%, and you have to treat 100 patients, so one benefits. I don't know. I mean, but I just know in my core that that product cannot be 50 times more than whatever it's replacing. So yeah, I mean, negotiating these prices to, so they're more in line with what other, countries are paying, I think it's absolutely unfair to Americans for it to be any more. I
So
mean,
how
and
do you,
I don't see how that argument, I mean, I know that we're the biggest market and so on and so forth, but there's just no reason why American taxpayers or consumers or patients should pay 5 times more for a Pixaban than people in the UK or something. I mean, there's just no reason for
So,
that.
I mean, pe people worry that if you end up having government negotiate drug prices, you, you lose that free market mentality
But
that we
it's
have in
it's not a
America.
free the free there is no free market. We're so far outside of the free market. I feel like
Tell me
that's
why. Tell
not
me why.
that because a free market would be the price that patients are willing to pay when offered the choice between, X, Y, and Z. I mean, and that's not how it works. We know that.
So,
I
so it's
mean,
it's what patients because it's the payers who are paying, and because it's not really direct, it's not the patients who is paying. That's why it's not free market.
right. And I mean, the patients have no involvement in it whatsoever. I mean, we can't even really choose. I mean, our ability to even choose the kind of insurance products we want is severely limited and restricted by our laws. So I mean, I think that we have to get out of the idea that we have a free market. And we don't have anything even like a free market. So
Yeah.
I just yeah, and I don't I mean I don't worry so much about, and this is not meant to be like a dig at people that work in pharmaceutical industry or the, medical device industry, but my concern is not really so much for the health and well-being of those individual companies. I mean, I'm looking at it more from the standpoint of like patients and public health. And I feel like our unwillingness to negotiate on some of these things was simply just because of the influence of these companies on our politicians.
Yeah. Wow, there's a lot of that we had a discussion about. I think you left a lot of thoughts. I'm not sure we
Oh, but
came up to a
well, no,
resolution.
I do want to say, I want to say before we end that I think that Trump should get a lot of the credit for people finally talking about negotiating drug prices. If you recall, remember that was a big point of like his campaigning before uh his first term in office, and he spoke about that a lot. And I think that he brought a lot of life to that topic. And I don't think he gets credit for that.
No, I don't think he does.
He
I
doesn't get
think
credit for much, but I mean, I think in particular that is an issue that he was pretty vocal about.
yeah. Well, Andrew Foy, it's always a fun conversation to have you, even if we didn't really have a resolution to the problem. I think I'm going to title this episode, physicians and conflict of interest or something like that, because we talked about a lot about this, but I think that probably my editorial last comment is that the physicians are being influenced by so many forces in the American healthcare market, and I think you're right. I think probably if patients were determining how much to pay and what to order, I think things would be very different. It used to be the case in the 60s.
No, I agree with you 100%.
Yeah. Dr. Andrew Foy, the always controversial boxer here on Healthcare Unfiltered. Thank you so much for coming on.
Yeah, thank you.